everybody for joining us for the Canadian Heart Failure Society Symposium at Heart Failure Update on heart success. What can Canadians do to fight heart failure? My name is Dr. Shelley Zeroth. I'm Professor of Medicine at the University of Manitoba and the past president of the Canadian Heart Failure Society. And these are my disclosures. I'd really like to thank our planning committee and distinguished faculty for contributing to the Heart Success program. And this program has received financial support from Novartis Canada. Today, we're going to talk about the state of heart failure care in Canada. We're going to tackle the new standard in HFrEF management, looking at the ACC pathway and the CCS guidelines. We're going to talk about the Canadian Heart Failure Society order set as well, and how you can use it in your hospital. And of course, we're going to have a live Q&A at the end of this session, and will be available behind the scenes as well for chatting. These are our learning objectives. And a reminder, send your questions to us in the Q&A box on your screen. And again, the faculty will be there behind the scenes watching and listening, and then we'll do some live Q&A after the recordings are done. Now, I'd like to take this opportunity to introduce to you Dr. Stephanie Poon, Assistant Professor at Sunnybrook Hospital in Toronto, Ontario. She's Medical Co-Director of the Heart Function and Rapid Cardiology Assessment Clinic, as well as Dr. Sean Varani. He's head of the Division of Cardiology at Providence Health Centre in Vancouver. He's past president of the Canadian Heart Failure Society and medical director of the Heart Life Foundation. And they'll be speaking to you about the state of heart failure care in Canada. Take it away, guys.
Thanks very much for the introduction. Today, Dr. Varani and I are going to start off this seminar by giving you a quick update about the state of heart failure care in Canada. These are my disclosures, and Dr. Varani's. But before we delve into the present state by reviewing the findings of our Canadian Cardiovascular Society Heart Failure National Quality Report, I would like to take a look back at the past. And I have to say that these past couple of decades have been truly exciting for all of us in the heart failure world. During this time frame, numerous advances have been made in the realm of medical and device therapies, which have all been shown to decrease hospitalizations and reduce cardiovascular mortality for patients with heart failure with reduced ejection fraction, or HFrEF. However, the million-dollar question is, have all of these fantastic breakthroughs actually translated into better outcomes for our patients with heart failure out in the real world? In order to answer this question, the Canadian Cardiovascular Society Heart Failure Quality Indicators Working Group collaborated with CHI to produce our first National Heart Failure Quality Report. Our objective was to determine if there was any change in 30-day readmission rates of patients admitted with heart failure across Canada from 2009 compared to 2018. We also wanted to describe trends in heart failure length of stay, since this could influence readmission risk, both as a process of care related to the timing of hospital discharge and as a proxy of patient-related factors leading to increased risk or rehospitalization. Overall, our conclusions about the state of heart failure care in Canada were quite sobering. First of all, our analysis of national level hospital discharge data from 2009 and 2018 demonstrated that the 30-day readmission rate of patients with heart failure had remained static at approximately 20% over the past decade. Additionally, the total number of heart failure admissions had increased by about 15.8% from 2009 to 2018 at a rate that is currently outpacing population growth. Of note, decompensated heart failure was actually the most common cause for readmission. Finally, it appears that the median length of stay has remained unchanged at 6 days between 2009 and 2018. When we did a deeper dive of heart failure length of stay in 2018, it appears that the majority of patients ended up staying in hospital between 7 to 13 days across the country. This is important because we know that length of stay greater than 5 to 6 days is associated with increased risk of all-cause readmissions and mortality, as illustrated by this figure. Since the study was based on hospital administrative data, it has some limitations which are highlighted by this slide. However, until a national heart failure registry can be created, that will enable us to track patient and system level outcomes across the care continuum. Administrative data from CHI can still be used as a powerful source of information for potentially identifying gaps in process of care that can then be addressed to improve patient outcomes. These findings have clearly indicated that there is a significant need for improvement in the delivery of care to patients with heart failure in Canada. Dr. Vrani will now highlight how the CAN-HF registry is assisting us to optimize the treatment of our patients with heart failure moving forward.
Thanks, Dr. Poon, and it's my pleasure as well to speak today on CAN-HF, which is a Canadian multi-center retrospective non-interventional study of inpatients and ambulatory patients with heart failure. I've had the opportunity to present this at the Canadian Cardiovascular Congress last year on behalf of the CAN-HF Steering Committee, and it's my pleasure to do so again today. I also want to acknowledge the study sites that were involved with the CAN-HF team, and they're listed here. Last year, we had the opportunity at CCC to present the baseline demographics of the entire cohort, and my comments today are really going to focus on the patient population with heart failure with reduced ejection fraction, both in the inpatient and the ambulatory setting. So when we look at the inpatients in the CAN-HF cohort, we see that there were 943 patients admitted to hospital with acutely decompensated heart failure in the CAN-HF registry. 56% of those were male, and the remainder, of course, were female, with a mean age of 76. It is important to note that 64%, or nearly 2/3, had a history of heart failure, while approximately 1/3 were de novo heart failure patients. In the bottom pie chart, you can see that the vast majority of these patients were elderly, over the age of 65, and in fact, an even larger number over the age of 75. This first set of bar graphs lists the common comorbidities in this group of patients. Other is the largest because it's sort of an amalgamation of all the smaller diagnoses, and so we see that coming out on top. But when we look at the cardiac specific diagnoses, we see that 68% of patients had hypertension, 43% atrial fibrillation, 42% coronary disease, and 40% of patients admitted to hospital with acutely decompensated heart failure had diabetes. About 30% of patients had been admitted in the prior 12 months, so recurrent hospitalization rates were reasonably high. Devices were generally underutilized in this group. And of course, we're looking specifically today at those with heart failure with reduced ejection fraction, which was about 52% of the overall cohort. I really want to draw your attention to medication utilization at admission and discharge. I'm gratified to see that when you compare when patients came into hospital to the time that they left, that is the blue bars to the gray bars, there was generally an increase in all the classes of medications that we know to be important in the management of heart failure with reduced ejection fraction. And I specifically want to draw your attention to the disease-modifying agents such as beta blockers, ACE-ARB, MRA, ARNI, and ivabradine. We also know that in some patients who aren't able to tolerate RASI, the combination of hydralazine and isosorbide dinitrate is often used. Again, generally speaking, there was an increase across the board in the use of guideline-directed medical therapy from the time of admission to discharge. I want to shift focus quickly onto the outpatients with heart failure with reduced ejection fraction. These were patients that were seen in the ambulatory setting and didn't necessarily have to have had an acute heart failure decompensation. There were 1,775 such patients in the CAN-HF registry. Again, 2/3 male and 1/3 female with a mean age of 70. An elderly cohort, again with the majority being over the age of 65. In general, these patients were being seen in routine follow-up in the ambulatory setting. And of note, the comorbidities are exactly the same as we saw in inpatients with heart failure and reduced ejection fraction as well, with relatively high frequency. Again, I'm really pleased to mention that medication utilization from the first ambulatory visit to the second visit was significantly increased in this patient population. Whether that's beta blockers, diuretics, or MRA, we see that there was increased utilization of this medication between visit 1 and visit 2. Of note, ACE and ARB actually decreased between the first and second visit, but that's paired with a significant increase in the use of angiotensin receptor and neprilysin inhibitor between visit 1 and visit 2. So again, a signal to really augmenting heart failure therapies in this patient population. So in summary, the use of guideline-directed medical therapy is improved in our HFrEF patients in both the hospitalized and the ambulatory settings, but certainly there continues to be an opportunity for improvement when we look at those bars in the last couple of charts. We know that patients with HFrEF have a high burden of comorbidity, and I've tried to show you what some of those common comorbidities are, particularly from a cardiovascular standpoint. And I also think it's really important to note that greater than 30% of patients that were admitted to hospital had de novo heart failure. So these were new patients, and we have a real opportunity to impact their care with the application of guideline-directed medical therapy. So thank you very much, and we look forward to your questions.
Thank you very much, Dr. Poon and Dr. Virani, for that wonderful presentation. I now have the distinct honor of introducing to you our international faculty, Dr. James Januzzi. He is the Hutter Family Professor of Medicine at Harvard Medical School. He is the cardiometabolic faculty at the Baim Institute for Clinical Research. He's a trustee for the American College of Cardiology, associate editor of JACC. He's published more than 600 manuscripts and book chapters, and he's the top 1% of cited researchers according to the Web of Science. He will be speaking to us about the guidelines for the WIN and the ACC pathway, and then I'm going to join him at the end of his presentation. So take it away, Dr. Januzzi.
Thank you very much, Madam President. And everyone, I just want to thank you all for the opportunity to speak today. You know, if there's anything positive that's come out of the pandemic, it's that it's given us a chance to draw together more closely with meetings like this. So I want to thank the organizers for including me. And it's really exciting to be able to talk about how we can apply recent understanding from clinical trials to more optimally manage our patients with heart failure and reduced ejection fraction. My disclosures are seen here. What Dr. Zeroth mentioned is important. I work at the Baim Institute for Clinical Research and am a clinical trialist working on several industry-sponsored trials. More importantly, one other disclosure that is mentioned is that I am a trustee of the American College of Cardiology and have had the opportunity to be the vice chair of both the 2017 and 2021 update for the American College of Cardiology Heart Failure Expert Consensus Decision Pathway document. So these documents focus not so much on the why we should be using certain therapies for management of patients with heart failure, but really focus more on the how, which is to say the deployment of therapies that we recognize are beneficial for our patients with heart failure and reduced EF. And in the 2021 update to the ACC Expert Consensus Decision Pathway document, there are two major changes with respect to heart failure therapeutics. And as you'll see, our recommendations are so very similar to the Canadian guidelines as well. These changes include the movement of angiotensin receptor neprilysin inhibitors, or ARNIs, to the preferred first line as the renin-angiotensin inhibitor of choice, this concept of ARNI first, as well with all of the fantastic data focused on the use of SGLT2 inhibitors in HFrEF. We also recommended them to be a part of the 4-component frontline therapy for patients with HFrEF. So let's go through the logic for how and why we got to where we are. Everyone recognizes the monumental result of the Paradigm HF study, which for the first time showed that a replacement for foundational therapy, so a replacement for ACE inhibition, specifically sacubitril valsartan, was able to reduce cardiovascular events with a 20% reduction in cardiovascular death and heart failure hospitalization. What may not have been recognized by many at the time was that the effect of sacubitril valsartan on the mode of death interestingly seemed to be similar, whether we focus on pump failure death, which we might expect from a drug that inhibits the renin-angiotensin system, but notably there was a similar reduction in the risk for sudden death. Indeed, if you look at the risk of sudden cardiac death in patients with a defibrillator or those without a defibrillator, we see reductions. And this finding was particularly noteworthy in patients with non-ischemic cardiomyopathy. Now, for those that may not remember the history of the Paradigm study, this was done without a phase 2 trial to examine the mechanism of benefit from sacubitril valsartan. So the main result of Paradigm, together with these findings, made us start to think that maybe that the mechanism of benefit of sacubitril valsartan was an impact on cardiac remodeling and an improvement in ejection fraction, given the reductions in sudden death that we saw. And indeed, in the PROVE-HF study, after 12 months of treatment with sacubitril valsartan, despite a background therapy of ACE inhibitor or ARB in study enrollment, patients switched to sacubitril valsartan had an average 9.4% improvement in ejection fraction by 12 months after study enrollment. And notably, a full 25% of the subjects in the study had an ejection fraction increase in the double digits, an average 13% or greater by 12 months. So again, despite a background of ACE inhibitor or ARB in the vast majority of patients, being put onto sacubitril valsartan resulted in this rather substantial increase in ejection fraction. In parallel, we also observed a rapid and substantial improvement in health status as assessed by the Kansas City Cardiomyopathy Questionnaire. So by 14 days after initiation of sacubitril valsartan, there was a clinically significant improvement in KCCQ of 6 points. By 60 days, that had risen to 9 points, and notably, 1/4 of the subjects had a KCCQ improvement of 20 points or greater. This is a kind of improvement in health status that you see in patients who receive cardiac resynchronization therapy or left ventricular assist device placement. So it's a rather substantial improvement in quality of life and health status. In addition, it has not gone unnoticed that the data supporting the role of sacubitril valsartan in hospitalized patients, an ideal environment to switch patients or initiate de novo patients on sacubitril valsartan, was also substantial, with a significant reduction in NT-proBNP and a reduction in the risk in particular of rehospitalization by 30 days. Among those patients treated with sacubitril valsartan versus enalapril in acute HFrEF. So in totality, the writing committee felt that the data were clear at this point, that recommending going direct to an angiotensin receptor neprilysin inhibitor rather than recommending a 30-day trial of ACE inhibitor or ARB made more sense. And this speaks to the fact that there's really no biological plausibility for starting with an ACE or an ARB and then switching to an ARNI. Furthermore, de novo initiation of sacubitril valsartan is actually even more well tolerated than starting on an ACE ARB and then transitioning over. And this was shown in the transition study, the Pioneer study, and IMPROVE-HF. Furthermore, the benefit of ARNI appears very early after initiation. So why would you deny your patients of this early benefit with a period of ACE inhibitor or ARB before switching them over to ARNI? Furthermore, de novo patients don't only tolerate the drug better, but there's also more reverse cardiac remodeling. Ultimately, most fundamentally, waiting for failure of ACE inhibitors or ARBs to intensify to sacubitril valsartan is exactly what we're trying to prevent, and also reduces the likelihood that the change will occur. The other major change in the expert consensus decision pathway document was the recommendation to adopt SGLT2 inhibitors as a frontline therapy as part of the 4 pillars of heart failure management. And this is on the basis of the DAPA-HF and EMPEROR-reduced studies. In DAPA-HF, among a very well-managed patient population, the addition of dapagliflozin was associated with improvements in the primary endpoint of heart failure hospitalization, urgent heart failure treatment, and cardiovascular death. Notably, there was a significant impact on each of the components of the primary endpoint. In the Emperor-reduced study among a somewhat higher risk patient population, we were able to show that treatment with 10 milligrams of empagliflozin added to standard heart failure care, approximately 20% receiving ARNI in this study, reduced the primary endpoint of cardiovascular death and heart failure hospitalization with a significant impact on first and recurrent hospitalizations. Notably, consistent with the benefit of SGLT2 inhibitors to improve cardiorenal risk, we showed in Emperor Reduced that treatment with empagliflozin was associated with an attenuation in the downward slope of eGFR deterioration compared to those patients treated with placebo. And if we look in a meta-analysis of Emperor Reduced and DAPA-HF, we can appreciate the rather profound benefit of SGLT2 inhibitors on cardiovascular as well as renal endpoints. Now, people have asked whether this is just simply an impact on glycemic status, and we know that this is not the case. In DAPA-HF as well as in Emperor, treatment with SGLT2 inhibition was beneficial irrespective of a background history of type 2 diabetes. Mechanistically, to understand this better, studies have been done looking at the impact of SGLT2 inhibition on top of usual care, showing much like the drug, the studies that we did with sacubitril valsartan, that treatment with empagliflozin in this case was associated with substantial reverse cardiac remodeling, as well as improvements in VO2 max, as well as quality of life. But importantly, ladies and gentlemen, we make the argument that this is not an either or choice because data clearly indicate that angiotensin receptor neprilysin inhibitors and SGLT2 inhibitors are additive for their benefit, such that we see an improvement in outcome when each is added to the other. When we look at the expected lifetime benefit, if we apply this comprehensive disease-modifying therapy in chronic heart failure with reduced ejection fraction, we can expect a substantial, more than 8 additional years of event-free survival for a patient receiving angiotensin receptor neprilysin inhibitor, an evidence-based beta blocker, spironolactone or eplerenone, and SGLT2 inhibition versus conventional therapy. So really, it makes the compelling argument that the time is now to implement these life-saving therapies for our patients. Now, with that, I'd like to turn it over to your immediate past president, Dr. Zeroth, who'll be speaking about the Canadian Heart Failure Society Heart Failure Guidelines.
Superb. Thank you for that wonderful talk. And I think great minds think alike. These are the CCS, Canadian Heart Failure Society Heart Failure Guidelines update from 2021. And because I need glasses to see this, my friend, can you hit for the next slide and blow this up for me? Perfect. There, now I can see it better. And of course, this is very similar to what you discussed in the ACC pathway, in that we now have 4 standard therapies. You refer to them as pillars as well, but there are 4 standard therapies for the management of HFrEF. And again, very much like the ACC pathway, we also do suggest ARNI first line. And for all the reasons that you stated in your talk. Of course, beta blockers, MRAs, and SGLT2 inhibitors. This is the second time we've introduced SGLT2 inhibitors as part of the concept of quadruple therapy, but we've modified the guideline based on the addition of the Emperor reduced data. And then furthermore, we also discuss the assessing the clinical factors for additional interventions, including residual heart rate addressed with ivabradine. Those with recent heart failure hospitalization or worsening heart failure, we suggest considering vericiguat as well. And then izardil hydralazine in appropriate populations. And on top of it, digoxin has made a reappearance. It sort of disappeared from our algorithm in 2017, but for a very select population. Can we go to the next slide, please? And this is the text surrounding the official guideline recommendations. On the panel on the left, you see that, again, the 4 main standard therapies with ARNI, beta blocker, MRA, and SGLT2 inhibitors. In addition, in the second panel in the middle, we recommend that patients admitted to hospital with decompensated heart failure should be switched to an ARNI. And furthermore, we also suggest patients admitted to hospital with a new diagnosis of HFrEF should be treated with an ARNI as well. Again, very much based on that pioneer data that you presented so nicely. And of course, on the final panel, we've expanded our SGLT2 recommendations to include the data from EMPEROR Reduced in the management of patients with HFrEF. And furthermore, we've also added in the data based on some of the CKD trials showing a reduction in hospitalization for heart failure when using SGLT2 inhibitors in the presence or absence of type 2 diabetes. Next slide, please. So I think we've really have very similar approaches across the border, at least in terms of the management of HFrEF, which I hope will lead to great heart success. Quadruple therapy is the new standard of therapy, as we'll talk about very much throughout the Heart Failure Update program. The priority now is to initiate all 4 standard therapies, then up-titrate. We've seen some very impressive data regarding the favorable remodeling that this comprehensive therapy will provide. It improves clinical outcomes and, importantly, also quality of life. And based on the new CHFS guidelines, the populations for consideration of sacubitril valsartan clearly have expanded. And remember, in-hospital initiation should be considered. Thank you very much. And now I would like to move on to our next talk about implementing the CHFS order set in your hospital. Again, we're going to have Dr. Stephanie Poon, Assistant Professor from Sunnybrook, who you've already heard from, as well as Dr. Katie Connolly. She's a cardiologist at the Hamilton General Hospital, Assistant Professor at McMaster University, and you're going to be hearing all about this new order set and how you can use it in your hospital. Take it away, ladies.
Thanks very much for the introduction. Today, we're going to talk about how you can join in the fight against heart failure by implementing the Canadian Heart Failure Society order set in your hospital. We have 3 main objectives for this session. First, we'll discuss the use of a standardized order set to help guide the management of patients who are hospitalized with heart failure. Next, we'll review the key components of the CHFS heart failure order set. And finally, we will illustrate how this heart failure order set can be applied to your own institution. So why is a standardized order set needed for heart failure patients? Well, one of the main reasons is that the burden of heart failure in Canada is extremely high. Currently, we have well over 600,000 Canadians living with heart failure. Heart failure is the 3rd highest cause of hospitalization, and overall, it is estimated that heart failure will cost the Canadian healthcare system approximately $2.8 billion by the year 2030. Despite advances in medical and device therapy, the mortality rate of patients with heart failure remains quite high. To put this into perspective, we know for a fact that the mortality rate of heart failure is higher than some cancers. For example, heart failure has a lower survival rate than breast cancer in women and prostate cancer in men. We also know that with each hospitalization, the risk of readmission increases and survival decreases. By 5 years, the mortality rate is 50%. Also, every time a patient is hospitalized for heart failure, they are back in hospital about 28 days faster than the last time. This means that by the time that patients are on their 5th heart failure hospitalization, it is expected that they will be readmitted within 60 days, and their overall survival is estimated at 90 days. So, what can we do to break this vicious downward spiral? Well, we know for a fact that guideline-directed medical therapies, including some of the newer medications that have already been discussed, can most definitely assist in improving heart failure outcomes. By ensuring that all of our patients with HFrEF are on quadruple therapy, we will be able to guarantee them the best outcomes. In other words, the more classes of heart failure medications we manage to get our patients on, the lower their overall mortality will be. Specifically, a patient with HFrEF on 0 medications has a 2-year mortality of 35%. If we manage to get them on quadruple therapy with ARNIs, beta blockers, mineralocorticoid antagonists, and SGLT2 inhibitors, this number decreases to 9.5%. However, studies have shown that despite all of these findings demonstrating the importance of quadruple therapy, patients with heart failure are still receiving suboptimal care. The CHAMP-HF registry included US outpatients with chronic HFrEF. Despite the fact that less than 2% of contraindications to these medications, overall less than 75% of eligible patients were initiated on these therapies. Use of both mineralocorticoid antagonists and angiotensin receptor necrolysin inhibitors was particularly low at 33% and 13% respectively. So it is obvious that generally speaking, we are just not so good at optimizing heart failure medications when patients are already discharged home. One of the strategies that we could use is to think about medication optimization way before that point happens. Hospitalizations are generally the best time to change a patient's medications. First of all, you know that if they ended up in hospital, what they were on was probably suboptimal in some fashion, so the pathway to improve heart failure outcomes really should begin on admission. However, that Newton's first law of inertia is very powerful. There is often that common tendency to wait until we see the patient back in clinic in a couple of weeks to change things. But the reality is, patients nowadays don't even want to come to clinic because of COVID or they're quarantining at facilities, so they may not actually get started on the right medications if we delay. Our message is to act right now and help patients get the greatest benefits as early as possible. And that is where the idea for the CHFS Heart Failure Order Set came into being. We know that implementation of standardized order sets in the acute care setting has been consistently shown to improve outcomes in heart failure. A large retrospective analysis of heart failure order set use demonstrated significant benefits for in-hospital implementation of a heart failure order set, including a reduction in mortality and length of stay. I'll now hand it over to Dr. Connolly to speak a bit more about the CHFS order set and how it can be used to guide clinical management at your hospital.
Thank you, Dr. Poon. As Dr. Poon discussed, the hospitalization of a heart failure patient represents a really critical time point in the evolution of their disease, but it also is an opportunity where we can optimize their medical therapy. The Pioneer HF study compared in-hospital initiation of Sacubitril Valsartan to enalapril and found that in-hospital initiation was in fact safe and reduced the NT-proBNP from baseline significantly compared to enalapril, which is an important prognostic indicator. So what are the components of an order set when you're developing an order set for your center or modifying your existing order sets? Many will have non-pharmacologic care instructions, including daily weights, fluid and sodium restriction. Many will have laboratory investigations needed to diagnose and treat heart failure, as well as, of course, medications. Some even include discharge order sets, which are becoming more common, although this order set does not specifically include a discharge order set. Ultimately, order sets ensure that critical components of patient care are considered with each heart failure admission. Some of the non-pharmacologic strategies, as mentioned, would be sodium and fluid restriction, daily weight monitoring, a diuretic sliding scale, as well as smoking cessation, etc. You could also consider adding in triggers for when to escalate the patient's care to a more highly intensive monitoring or to involve specialized heart failure care. So this is the Canadian Heart Failure Society Heart Failure Order Set, which is available on the CHFS website, and I'll provide the link at the end. This is fairly standard components of an order set: diet, intravenous monitoring, blood tests to do on admission. This is where the medications are outlined, and I think this is one of the unique components of this order set that make it very user-friendly and also helpful for the prescriber. And there's real focus on providing information and education to the prescriber about the different medications. For example, at the top here, you can see that they've included the ARNI eligibility criteria for those who may not be as familiar with this. There's also some detailed instructions for ARNI initiation, as well as conversion from an ACE inhibitor or an ARB, as well as alternatives to consider if ACE inhibitors or ARBs are not indicated, and also provides the thresholds for when you might not be able to start a patient on an ACE or an ARB. There's also this handy conversion table, which is very practical to convert ACEs to ARBs or ARBs to Sacubitril Valsartan. And then here, different classes of evidence-based heart failure therapies are outlined: mineralocorticoid receptor antagonists, sinus node modulators, SGLT2 inhibitors, with the indications for each of them and recommended initiation regimes. Again, many heart failure order sets are also going to include other cardiovascular medications and other medications that might be commonly administered in hospital patients, such as antiarrhythmics and anticoagulants. But again, this is all very center specific and specific to your needs in your own center. So as a case study, we reviewed our St. Joseph's Hospital current heart failure order set, which is actually only a couple of years old, and worked through how to update it with the new CHFS order set. So this is how the medications are outlined: ACE inhibitors and ARBs, vasodilators, as well as beta blockers and ARNI. And when we went through, we identified a couple issues for correction. One is that some more novel heart failure medications, such as avapritinib and SGLT2 inhibitors, are not on the order set, and those needed to be added. We wanted to include more eligibility criteria and as well as contraindications for the medication classes, and include more practical information on switching ACE inhibitors and ARBs to ARNI, and also make sure that we highlight that ARNI is now a first-line therapy in heart failure with reduced ejection fraction, in keeping with the 2020 Canadian guidelines, and as well prompt the prescriber to justify why they may not be prescribing certain medications, which I think is also an important point. So take-home points from our discussion today. One is that hospital admission is a unique opportunity to optimize heart failure management. Two, dedicated heart failure order sets reduce mortality and hospital length of stay. And three, you don't need to reinvent the wheel. You can personalize the order set in your institution while following best practices by using the CHFS order set, which is found at hfordersets.ca below.
Okay, I'll ask our faculty. Wonderful presentations. I'm going to start off with a question, of course, for our international faculty, Dr. Januzzi. You presented some really interesting data about the Sacubitril Valsartan. Is that kind of data to influence device referrals and device optimization for patients in terms of ICD referrals?
Yeah, that's a really important question, right? Because we have seen in other device studies like the COAPT trial versus MITRA-FR that optimization of medical therapy, if a patient is still eligible for whatever procedure we're talking about, in this case ICDs, but the example I'm giving is for mitral regurgitation and mitral clipping, only after optimization of medical care was the COAPT study, much more significantly successful than in MITRA-FR. And the same thing goes for defibrillator therapy, in the sense that if a patient is treated with optimal therapy and they are still eligible for an ICD, of course, it's going to be much more effective. So your question speaks to the impact of sacubitril valsartan on ejection fraction. And the question that naturally comes out from the PROVE-HF experience is, if you started somebody on sacubitril valsartan and gave them the time to reverse remodel, what would that do to their eligibility for a defibrillator? So we looked at this question. We looked at the 613 patients that had an EF less than 35% at baseline, so ICD eligible. And we looked at the trajectory of ejection fraction at 6 months and at 1 year. And what we saw was that by 6 months, 32% of those patients had risen their EF to no longer being ICD eligible. And by 1 year, 61% had risen above 35%. Now you might say, wait, I'm not going to wait a year. My patient may die suddenly during that period of waiting for medical therapy to work. And I understand that concern. So we looked at what percentage of the patients had an arrhythmic event or died suddenly, and the answer was none. So at least in the context of that 1 year experience of 700, 600 patients, the calculus really would favor giving the patient a chance to have optimal medical therapy and respond, thus potentially avoiding the need for an implantable defibrillator. Of course, if a patient has clinical indications for it, that's a completely different story, but what we're talking about is primary prevention.
Thank you. Dr. Varani, tackle some of the CAN-HF data, which I think is very intriguing. Thank you for presenting that. I'm looking forward to the publication. What are the barriers to better uptake for hospitalized patients for guideline-directed medical therapy in hospital?
So thanks for the question and thanks for the opportunity of presenting. I think there's going to be multiple elements to that answer. I could lean on Dr. Poon, who I know has some analyses from the CHI data to suggest that where a patient is located or admitted to in a hospital, or who the most responsible physician is, may have some implications in terms of the veracity with which guideline-directed medical therapy is implemented. So if you're potentially admitted under a cardiology service versus an internal medicine service versus a primary care service, there may be varying uptake of guideline-directed medical therapy. That kind of leads into my second point that I'm going to make, though, is that there may be significant bias in terms of where a patient is admitted based on their comorbidity burden, their overall trajectory, their prognosis. And there is a certain degree of stratification and triage that I think happens in the emergency room and in all of our practices in terms of where a patient may ultimately land. I think it's important that we realize that when I showed you those graphs of in-hospital, prescription of any of these guideline-directed medical therapies, that it's simply unrealistic to expect that 100% of our patients will be on 100% of these therapies. Dr. Ducharme, our president of the CHFS, did a really elegant piece of work in Montreal, published actually in JACC HF under Dr. Januzzi's, I think, leadership, looking at this issue of physiological sort of tolerance, if you will, of heart failure therapies in the ambulatory setting. And I would expect that in the in-hospital setting, it's kind of the same thing. There are limitations based on heart rate and blood pressure and renal function and all kinds of other biological parameters, which are going to limit our ability to up-titrate these medications or in some cases initiate these medications. So that's a really roundabout way of saying things, but ultimately I think when you look at the work that Dr. Connolly and Dr. Poon presented in terms of heart failure order sets, it's a great way of increasing uptake and decreasing the barriers, if you will, in terms of prescribing. We know there are lots, I've highlighted a couple of them, but if we can go through a systematic approach in terms of therapies and why we are or are not prescribing them, I think it'll be less of a barrier to uptake and better outcomes for patients.
To a question about the quality indicators, and thank you for being one of the co-chairs of our CCS Heart Quality Indicator Committee. I know work. In the data that was presented, it was evident that the length of stay is 7 to 13 days for heart failure in Canada. Report that the use of standardized order sets would impact that length of stay in any way. After you're done, I'm going to go back to Dr. Januzzi to see what they...
Well, I know that we certainly have evidence that the use of order sets decrease could potentially help in decreasing length of stay and also repeat hospitalizations as well. So that is one of the thoughts and benefits of potentially having the order set. I mean, it really is to try and facilitate use of evidence-based medications that may otherwise, you know, right now we've got quadruple therapy with more possibly to come down the pipeline. And I think there's the overarching sensation that it may be a little bit overwhelming. You know, how do you start these medications? When do they come into play? If we wanted to do it, what are some clinical pearls and tips that we would have to keep in mind? So I think the CHFS order set, by embedding these clinical pearl suggestions and tips, what to look out for, et cetera, within the actual order set, would help in some ways to surmount some of these barriers potentially, particularly if patients are not being taken care of in the cardiology ward. There are studies to show that there may be differential uptake of prescription of guideline-directed medical therapies, or even diagnostic tests like echocardiograms, depending on whether patients are admitted to internal medicine or cardiology. And some countries like the UK have even developed policies to ensure that their heart failure patients have the involvement of specialists because of that. So I think the CHFS order set is a way of having kind of like a specialist at your fingertips, whether the heart failure patient is admitted to GIM or cardiology. You know, I think we're all striving to have the same standard of care everywhere, and the order set should help us achieve that.
Dr. Januzzi, how does length of stay compare with the length of stay?
Well, I think I'm going to avoid answering that question other than to say that length of stay is one of those interesting variables that when you look at, for example, the very American focus on shorter length of stay, that outcomes are actually worse when you try to rush a hospitalization. The ASCEND-HF study demonstrated in a global fashion, and I should try to find that slide to show because it's really amazing. It's essentially a perfect correlation with length of stay and likelihood for rehospitalization, such that locations that had the shortest lengths of stay, like the United States, 3 to 4 days, compared to, say, Japan, which often has up to 2 weeks, the likelihood of readmission was dramatically lower, and the sweet spot seemed to be around 7 to 9 days. So, you know, I think that more and more this is my own personal feeling, is that what we really should be focusing on here in the hospitalized patient, and yet another shameless plug for the ACC Expert Consensus Decision Pathway document for hospitalization that Dr. Poon showed in one of her slides. Optimizing heart failure care during the hospitalization is setting the stage for heart success in the outpatient setting. And there are many questions in the Q&A that really focus on this. How do we do it? Well, I mean, there are some simple but important observations. If someone comes into the hospital with a low EF, with acute heart failure, whether they're de novo or not, what I typically do, if they're taking an ACE inhibitor, I switch them to an ARB on admission so that I don't need to bridge them for 36 hours off of their ACE inhibitor. And I initiate ARNI actually fairly soon after a diuresis is established, because one of the questions is, what about hypotension? What I've learned from tailoring patients with the right heart cath and starting them on sacubitril valsartan is that their filling pressures, their wedge pressure, will go from 20 to 8, for example, in one case with the first dose of sacubitril valsartan, which is incredible. But it tells me that over-diuresis before initiating is a recipe for failing, you know, and then having to stop everything. That's not the case with SGLT2 inhibitors, which really don't necessitate a change in diuretic strategy. But by starting patients in the hospital, you put in place therapies that will then be continued on the outpatient side and up titrated. And one last point that I made in the chat, but for some reason it got all hacked up in the way it showed. we really strongly advocate for avoiding an either or. It's not ARNI, it's not SGLT2, it's 4 drugs, and aiming for getting low doses of all 4 on board before then titrating.
I think that that's going to be our final point from our discussion. Dr. Connolly, we haven't gotten a chance to get to you, but thank you so much for walking us through the heart failure CHFS order set. We really appreciate it. I like how Dr. Poon called it the specialist in your pocket. So I hope it's going to be a very useful tool for everybody. Again, thank you for attending our discussion today. If you wanted to download the CHFS order set, it's going to be a 2-page order set that will be available for download on the heart failure website, or you can go to hfordersets.ca and you can request a collab care session to implement the order set at your local institution as well. And in addition, we are going to have a new CHFS podcast. It was my first podcast that I'd ever done with Dr. Januzzi. We had a lot of fun, and so you'll see that on Spotify or Apple Podcasts in the upcoming weeks as well, so you can hear the conversation on the go. Again, thank you very much for joining us, and to Novartis for this program today. The online evaluation form will be program, and my understanding is that evaluations are being emailed to your individual sites.